All right, well, thank you for that introduction, Brian, and welcome everyone, and thank you for joining. As Brian mentioned, this presentation is going to be about data collection and the power of information in the practice of AOT. Data collection may seem unnecessary to the day-to-day practice of AOT, but hopefully by the end of this, everyone will understand how information and data collection can be beneficial to improving your AOT program, and we'll at the end provide some tips on how to get started. So as mentioned, my name is Elizabeth Hank. I'm the Director of Research at our Office of Research and Public Affairs at the Treatment Advocacy Center, and Kelly is our research assistant who's relatively new to the Treatment Advocacy Center, but has already created and contributed greatly, as you will hear. So just an overview of what we're going to be covering today. We'll first talk about the 3 W's of data collection, not necessarily the 3 W's you're used to, but the who, when, and why of AOT data collection. Next, we'll go through in detail the importance of data collection in AOT, and this will be coupled with real-world scenarios of how data collection and action can be useful. Then Kelly will go into some different types of AOT data, as well as sort of how to collect some of these different variables. And we'll briefly touch on some issues around data sharing, and then talk about how to get started and the first few steps to take in order to start collecting data in an AOT program. And hopefully at the end, we'll have about 20 minutes or so for a group discussion. So the first W is who can collect data, and really the short answer is anyone. But really, program evaluation is part of program management, and anyone that's involved in managing or operating a program can also be the person that collects data. Program evaluation is simply a systematic way to utilize information to examine your program. It's not this, scary thing that anyone should be afraid of. Importantly, program evaluation and data collection does not require outside expertise. There are a variety of different types and ways to conduct an evaluation, and does not necessarily need an outside researcher or an evaluator to do so. There are a variety of people attending today's webinar, including some evaluators of the SAMHSA AOT grants, but really everyone can collect data. You're maybe starting at different stages in a different type of data and evaluation that you may be doing. And so really data collection is just part of the program itself, which leads me to the next W, or when. So short answer of when to collect data is now. You really do not need fancy software or the outside expertise to begin. We really urge programs to start small and allow the process to proceed incrementally, and suggest including thinking about data collection when you're planning the program and really starting the implementation process. But you can also start after implementation has already begun. Also, it's really important to note that you do not need all data points in order to begin. You don't need to know where you're going to access all of the different data that we're going to talk about today. Even just small variables and indicators such as how many people are enrolled in the program and when their enrollment dates can really be beneficial towards your implementation of your program. So we'll be walking through the types of data to collect and some of our sort of wish list data points of what we think would be beneficial, but you do not need to collect every single one of these variables in order to begin your data collection efforts. So the next, perhaps most important W is why collect data. Really trying to, why can data collection help take your AOT program to the next level, or why is information powerful in an AOT program? So I'll be walking through each of these answers of why in detail, and each of them will be coupled with how the data can actually be put into action. So the first main purpose of data collection is to ensure that program goals are being met. Data really allows you to answer questions around, is your AOT program having the desired effect? This allows a more comprehensive understanding of how your program is operating, and be sure that your success that the AOT program is having is a measurable and success versus being anecdotal. So I really want to make the point here that goals and AOT program goals are program specific. It can include, any program can have any type of goal that is decided upon amongst the program themselves. These program goals can include an examination of outcomes, or looking at a more standard outcome evaluation, which includes an examination of the impacts, benefits, or changes realized by participants and the community as a result of the program. However, these outcome evaluations measures change, so it requires a comparison to the previous. But again, program goals are very program specific. So on the left-hand side, I have some examples of some more programmatic or process goals, whereas on the right-hand side, these are more outcome related goals. And so an example of a program enrollment goal is, say you're a relatively new AOT program, you might have a goal of trying to have 5 new AOT participants per month. Or you might have more of a referral level goal, which is trying to get referrals into the AOT program from different places that you, versus what you're currently operating, such as directly from the community rather than coming straight from the state hospital. Or you might have a more process level goal, such as trying to decrease the amount of time from referral to the program to actual enrollment, which can be a challenge, I know, in some programs, especially in California. So some outcome level goals include a participant outcome goal, so at the participant or individual level, such as increasing medication adherence, or a referral outcome goal, which is a percentage increase in the number of referrals, or more community level outcome goals, such as decrease in psychiatric bed days in the state hospital, or decrease in total law enforcement contacts. So the second way that data collection is beneficial is to track program data. These details can really assist in programmatic decisions. And I'll walk through sort of each of the different levels of program data here. So the first are inputs, or the resources dedicated to the program. And in an AOT context, this could include staffing, court time, any financial dedication, money to the program, or mental health services. Activities of the program, or what the program actually does, such as program monitoring, civil court filing, or status conferences, whereas outputs are direct products of the program activities, and this includes the number of participants served, the number of status hearings or conferences, or the number of court orders. And then outcomes are the benefits realized of the program, such as a percentage increase in quality of life indicators, or a percentage decrease in jail bed days. And so each of these different levels of program data can be collected in a systematic way, and even just the inputs level and collecting input data in a systematic way can be beneficial to making programmatic decisions. So some examples of that are, say that you are in a program where you have limited court time availability. So having a comprehensive understanding of the number of participants in your program and the frequency of which these people may require status conferences, whether it's weekly or bi-weekly or once a month, can really help create a court calendar and be able to understand and sort of balance out the status hearings throughout the month, so you don't have, say, 20 on one Tuesday and only 1 the next week. Another example is by collecting that level of enrollment or input data is how using the levels of enrollment and the fluctuations in caseloads over the course of the calendar year to help in determining staffing and AOT monitor caseloads. So the next benefit of data collection in an AOT program is around program improvement. And so this is a typical quality improvement paradigm within a public health context. And this is not necessarily the same thing as what I refer to as big P program evaluation, which is more of a overall examination and evaluation of the program itself. Rather, it's a systematic examination of program operations, outcomes, challenges, and solutions. And it really, this type of paradigm and following this can allow responsiveness to a community need and is a continuous ongoing effort to achieve measurable improvements to the program, and really can apply to a variety of different indicators. It doesn't necessarily only have to apply to outcomes or outputs. So for example, oh, and I'm sorry, I forgot to explain the paradigm here. So it's the PDSA cycle, which is the first is starting with a plan where you're identifying the problems. Do is trying different solutions. Study is using data to see how the solutions has impacted the problem and whether it's created a solution, and then act is implementing the solution at the end. And so this is an example of putting this into action. So a problem could be a program may have a low participant attendance to status conferences. And so data collection could allow the program to try to understand how the characteristics of participants differ between people that are high attenders or people that attend status conferences when they're supposed to versus those that do not. And then by using that data and understanding what separates the two groups, you're able to maybe fully understand what some barriers are to attendance for the people that are not attending. So do is coming up with some solutions, and some potential solutions here are to send reminders either through text messages if you have that capability, or through case managers calling to remind participants to come, or perhaps if transportation is a barrier, providing transportation money to participants in order for them to be able to attend the status conferences. And so in study, then you would look at how either one of those solutions had changed the attendance rates, and then ultimately implement whichever solution provided the optimal result. And I think it's important to mention here that the optimal result doesn't necessarily have to mean it's the most effective. You also have to consider feasibility in terms of, say, your program doesn't have enough, have extra funds to provide transportation dollars to participants, or you might decide that the case manager's time is not worth to spend that much time calling and reminding people. So it's important, it's the effectiveness of the solutions, but also the feasibility. So the next way that data can really help in improving in your AOT program is through creating public interest and understanding. Positive data and positive outcome results can lead to local media engagement. Greater public interest or understanding in the program can really help in generating more referrals into the program. An understanding of the program can help increase and strengthen partnerships with key stakeholders, whether it's the local service providers or law enforcement or others. And data and reporting that increases the understanding of how the program operates and its community value, which can really lead to increased program acceptability and accountability in the community. So an example of how data and the collection of data can lead to greater public interest and understanding is out of Summit County, Ohio, where there is a local media story on the positive outcomes of AOT that utilizes both participant data as well as outcome data. The story included basic program data, such as how many people were enrolled, what their outcomes were, and helped to educate the local community about the program and its impacts. This led to greater community buy-in and acceptability and increased trust in the program process. So lastly, data collection really helps with program sustainability. The sustainability of any program requires more than just funding, although funding is very helpful. The positive outcomes coupled with public interest can greatly increase the political support of your program. It also helps to maintain partnerships, which is also incredibly key for sustainability of any program. And lastly, data and positive outcome data can be used to advocate for more local funding. So an example of how this data has led to program sustainability and funding is from Judge Liu, who I believe is on the call, is going to share a story.
Thank you for inviting me. I was going to attend anyway as a participant, so thank you. So I'm Judge Cynthia Liu from Reno, Nevada. We began our AOT program in December 2016, where we started taking participants. We started data collection from day one, as I have some other specialty court programs, and data helps in multiple ways, including what's going well in your program, what you're lacking. We found a lot of our participants needed co-occurring treatment, so we added a substance abuse counselor to our team. Several were in need of vocational rehabilitation, so we added a trainer to the team. So it can really show you by taking or getting the data what the needs are in your program, as well as what's going well. Another important aspect of the data collection was I had to do a presentation before the Board of County Commissioners, and I was able to use the data to justify our program and show the positive outcomes of the program to gain that community support, and it was pretty well received by the county commissioners. I do meet quarterly with my IT department. So our court IT department helps generate and collate our data for us, as well as our AOT program director incorporates data from her points as well. And so I'll meet quarterly with the IT staff to review the data, and also we discuss our data at our monthly AOT stakeholder meetings. So that's how data has really benefited our program. We've been able to show a cost savings for reduced hospitalizations, as well as reduced jail days, which of course any county commissioner likes to hear. So that's how it's been helpful to us. So thank you.
Thank you for sharing. All right, so now I'm going to hand it over to Kelly to talk more about data collection and how to collect.
Hi everyone, thanks for coming. Like Elizabeth said, I'm Kelly South and I'm the Advocacy Center. So the first thing I want to talk about is the types of AOT data we collect.
Kelly, you're cutting in and out.
Oh, am I? Let me see. No headphones. Can you all hear me any better now?
Yes.
Okay, sounds good. Okay, so I'm going to talk first about types of AOT data that you could be collecting. But I want to preface it before I get into that with just a couple points to reiterate what Elizabeth already said. So first, you don't have to be a data scientist to be collecting this data. We think it can be done as simply as just entering basic information into a spreadsheet. And coincidentally, at the end of this webinar, we'll be providing you with a template Excel spreadsheet that could serve as a starting point for you all to begin collecting data or just to compare with how you're already collecting data. And then one of the major benefits we see of sharing similar variables that you could be collecting data on is that if we have all of our AOT programs across the country collecting the same data, then programs will eventually be able to compare against each other, and we'll start to be able to figure out which program aspects are working better than others, or where there's areas for improvement. And then lastly, before I get into it, I just want to say, we know there's barriers to collecting some of this data, but I just want to say don't let it deter you from collecting at least some of the data. I think that collecting some amount of data will always be better than collecting none. Okay, next slide, please. So we've broken it down into 4 categories that you can collect data under. So the first is participant information, which is just the basic information about your AOT participants. And then you've got participant history, which will be information about participants in the year leading up to their entrance into the AOT program. Then you've got program activities, which really relates to activities that the participant is doing as a result of being in the AOT program. And then finally, you have program outcomes, which is where we're sort of trying to measure the outcomes data that Elizabeth was talking about, and it gets a little bit more complicated, but you can also find more results to help you with program improvement and so on. Okay, next slide, please. So this is a screenshot of the Excel spreadsheet that we'll be sharing with you all. And I just want to walk through how to navigate it really quickly. So the first tab is definitions, which will just be descriptions of all of the variables that are listed on the spreadsheet. So if you forget what one means or just want to go back for reference, it's all listed there on the first tab. And then you've got the AOT participant info tab where you can enter in the basic information about your participants. You've got the 12 months prior tab where you can enter in data on them in the year leading up to their program admission. You've got during AOT where you'll be tracking monthly updates for each participant as they are enrolled in AOT. And then we also have post AOT, which data collection might get more dicey there, but if you happen to have access to some of this data, you can track outcomes for a participant after they've left the program. Next slide, please. Thank you. Okay, so let's talk about participant information first. I think the most important point on this slide is the first one about the record ID. So I think it's really important to assign a unique identifier for each AOT participant aside from just their name. So you could do something as simple as patient 1, 2, 3, 4, and so on, or you can come up with a more complex system if you want. But it'll help you track your participants in an easier way. It will get rid of doubles that you might have if you have participants with the same name, something like that. It's a nice way to keep track of your participants easily. And then we're also suggesting you collect name, commitment status, who referred the person to the AOT program, and then you've got a lot of dates as well. So date of initial enrollment, date of program start, and then date that they end AOT. And then we've also got demographic information, which is really important because we know that there can be different outcomes for different demographics. So if you're collecting this information and then analyzing it, you can start to see where there might be gaps between demographics and then try to bridge those gaps after identifying them. And then lastly, you've got notes, which I also think is really important. So really either the notes tab or a notes section on each tab in this spreadsheet. And I think just keeping miscellaneous notes on all of your participants that don't really fit into any of the categories we're mentioning is really important. You never know when you might want to refer back to that and it might shed light on an issue that you're having or something like that. Next slide, please. So here's a screenshot of an example of entering the participant information. So just always be sure to be tracking your participants by their record ID. I promise that will make things easier. And then you can see here that we've got patients by their record ID, commitment status, you could be ongoing or finished with the program, names, and then there's a drop down where you can choose who referred them to the AOT program. We've got all of the dates that I just mentioned. And then a cool feature at the end where it says weeks in AOT, it will automatically calculate the number of weeks that they've been in the AOT program based on the dates that you're inputting, which I think is cool, especially because we know that the longer time a participant spends in an AOT program, there might be better outcomes, and this could help us actually prove that or find out if that's true. So very important, and we've made it easy by just giving you a formula. Next slide, please.
Don't forget the Harry Potter for all those Harry Potter fans out there.
Yes, it is Harry Potter themed. Okay, so participant history. We've broken this up into 4 major categories, which you'll see again under program outcomes. So the 4 big categories for data collection are crisis contacts, psychiatric hospitalization episodes, criminal justice involvement, and then housing. And I will go into a little more detail on the next slide. Thank you. Okay, so here's an example of what that might look like when you're inputting it in a spreadsheet. So crisis contacts could really include anything like psychiatric emergency room visits, crisis center visits, contacts with mobile crisis teams, whatever you think might fit within that variable. Psychiatric hospitalization, you can be tracking the number of episodes, but then also the number of days that they spent in the hospital. And this is all in the year leading up to their participation in AOT right now. And then criminal justice involvement could be number of arrests or time spent in jail. And then housing, just really tracking their housing status if available. We know that all of this might not be available to you, and that's fine. Hence why there are a lot of blank cells on here, because we don't expect that you'll be able to fill in all of this data easily. And then also for housing, just to mention, we also recommend tracking, if you can, if they've been evicted in the last year or if they've moved to less restrictive housing. So say they've gone from inpatient living in a psychiatric facility to independent living or something like that. If you have that information, it would be great to track it as well. Next slide, please. All right, so moving on to the program activities. I think this is a great place to start for data collection because you should have relatively easy access to this information. So we've broken it down just to a couple of the activities that are primarily associated with participating in AOT. So that would be the number of formal hearings with a judge, the number of informal contacts or status meetings or whatever you might call them in your program, the number of contacts with an AOT monitor, court-ordered evaluations, and court-ordered medications. Next slide, please. So here's an example of that, and those variables all fall under the During AOT tab. So ideally, you would be tracking these variables every month. So as you can see, you can enter in the month and the year that you're reporting, keep track of them by their record ID, and then fill in as you can the rest of the cells. And also notice the notes tab in case you have anything that this isn't covering that you want to keep track of. Next slide. And And then lastly, we have the program outcomes. And this is pretty much mirroring the 12 months prior to AOT participation data categories, because they're very similar. And they will likely be more difficult to track. We know it requires more digging, and you might not have direct access to all of this information. But still don't let that deter you from trying, and maybe just start with the program activities and build on it after you've got a solid basis of collecting that data. So again, it's crisis contacts, psychiatric hospitalizations, criminal justice, and then housing. Yes, thank you. So there's an example of what that might look like. And that's also under the During AOT tab. So ideally, if you hear about this, try to keep track of what month it's happening under to keep up with the monthly reporting on each participant. And then if you're interested in using this spreadsheet or have any questions about it, please don't hesitate to reach out to Elizabeth or myself. Like Brian and Elizabeth have both said, we firmly believe that collecting data will benefit all AOT programs in the long run, and we really want to help you be successful in this. And I can help you overcome any data collection issues or advise on techniques or even help you analyze your reports and results. Okay, next slide, please. So I'm just going to briefly touch on data sharing. I think we could probably do a whole other webinar on this topic in and of itself, but I just want to put it in your all's minds as something that goes along with data collection. So what do I mean when I say data sharing? It can mean a number of things, but really here I'm just talking about sharing data among the offices that are involved in the AOT program, or even sharing among AOT programs or with the Treatment Advocacy Center to help analyze your results. So we know that information can be divided among different departments, and hopefully if you work on the data sharing practice, you'd be able to break down these information silos a little bit, and then just come to respect and understand the role that each office is playing in the AOT program, which is also really important. Next slide, please. So what are some of the benefits of data sharing? You'd have access to data that you otherwise would not. This provides wider opportunities for program evaluation, and like I just touched on, it could foster deeper relationships and connections with the others that are in your field. So it could help you in your day-to-day work if you're forging deeper relationships with the other offices that are working on AOT. We know it's a collaborative effort among a lot of offices, so this could be another way to connect with colleagues that you wouldn't be talking to all the time. You can collaborate to find out what's working well and what's not. That particularly applies if we're talking about data sharing across AOT programs. So it could be really interesting to compare the same data among programs that are across the country and might have different practices, see what's working well on certain outcomes and what might be able to be improved on others. So I won't go into much detail. I mean, I know there's obviously confidentiality concerns with data collection and data sharing, but that's, like I said, a whole other topic. Just wanted to put it on your all's radar as something to be thinking about when you're collecting your data. So that's all I have for the group. Thank you for your time.
The last thing I just wanted to touch on before we get into our group discussion is some first steps that we recommend to all of you in starting to collect the AOT data. The first being, make sure you check out the AOT learning modules on SMI Advisor. There's a whole, I believe it's module 7 on program evaluation and data collection that is very much similar to what we've covered today, but goes into some deeper detail in some of the other aspects, especially around evaluation and analysis. Second, as Kelly mentioned, we have this data collection spreadsheet that we created via Excel that we can share with you. It is something that we have developed, and it definitely can be modifiable, and we can work with all of you on different ways to change it, and it's walking you through the spreadsheet and how to use it in more detail. I really want to reiterate the fact that don't be afraid in data collection. It's important to just start small, proceed incrementally, and really you can even start as a pilot program in trying data collection out for a couple months and seeing how it goes, and then going from there. And as Kelly mentioned, please feel free to reach out to us with any questions. I believe I have our email addresses at the end of the presentation slides, but as well, I'm sure you all have Brian and Amy's emails, and they can connect you to us as well.
This is Nick Schranz. Can you hear me?
Yep.
So I guess this question may be for Brian or the entire Treatment Advocacy Center. One of the barriers to data collection from my perspective, and we've discussed this before in our Ohio AOT monitors groups, is getting the 12-month prior to AOT information. And my suggestion is that the power of the Treatment Advocacy Center would be helpful in getting that accurate data, so that when we do data collection, that the information's valid, that it's based on real data from the state that indicates the number of hospitalizations, et cetera. Because otherwise, my fear is that if it's based on a respondent's recall, a treating psychiatrist recollection at an inpatient hearing, which is where I get most of my information, then I think that the data collection loses validity. And so I would hope that we could improve the validity by getting better, robust data, accurate data that is most important. Well, I guess on both the pre-test and the post-test side. But that is, so I think for a lot of us, data collection during time in AOT is time consuming, but doable and reasonable and helpful. But it's the pre and post test that I worry about making sure that it's valid. Thank you.
Yeah, thank you, Nick. And thank you. I should have said that. Thank you to all the Ohio AOT monitors for really helping us think through data collection and really informing the spreadsheet that we have shared. So thank you for your work with us on this. And I totally agree, Nick. And I think, that's really why we try to emphasize in this presentation about that you don't necessarily need the prior data in order to start. And we really urge people to start. And even if you're just, like I said in some of my examples, that's why I used a lot of my examples weren't looking at pre versus post, but were actually emphasized on the during AOT and how that data can be used, because that's really a great starting point, is just collecting data on and getting that, worked into your workflows and that sort of thing. And then, then it's the next step of starting to address some of the validity of the data and sharing of administrative data from local or state entities.
Mm-hmm. Yeah, Elizabeth, do you have any thoughts about one of the things Nick raises, which I've also kind of struggled with and wondered about, is how do programs really make sure they're getting all the information about what a person went through before they enter the program? I mean, it doesn't really seem like enough to simply do an intake interview and ask the person, how many days have you spent in the hospital in the last year? You'd really have to have some kind of central repository of medical records to pull all that together, I would think. If you live in a place with lots of different hospitals, if the person is mobile and maybe went somewhere else, was hospitalized out of town, it seems challenging to pull all that together in a way that you can really empirically say we've reduced their days.
Yes, and that's exactly, that's going into sort of the big P of program evaluations versus in looking at the outcomes where you do need to rely on the pre side. And so, the validity of the data is very much important there from a research standpoint. However, I think, there has been research that has shown self-reporting among this population is higher than the validity of it is higher than one would maybe expect. And so, there's definitely, but there's limitations to all data and all research, I think. So, it's a balance of the benefits of data collection and starting this and doing this and, understanding the limitations. We're not suggesting that we all go out and peer review publish all of this evaluation. So, tomorrow, it's an iterative process that we're just sort of starting to begin.
Yeah.
But
Leslie, yeah, go ahead. I'm sorry. I thought you were done.
Administrative data, which is, a phrase to refer to like data that comes directly from the hospital or entity of some kind, is that in this scenario would be the best. But
yeah, and Leslie Carpenter in the chat box also raises a good point, which is it could be very helpful to get the person to sign a release of information so that you could go to all those hospitals in the area and just have them send over the records with the person's permission.
Yes, yeah, Betsy, do you want to talk about that? What you've done in Ohio with the release of information?
Sure. Can folks hear me?
Yes.
Yes.
Okay. Yes, Ohio is one of, I believe, at least 3 states now that have developed a standard authorization form. So basically what this does is any provider who receives the standard authorization form must accept it. So it helps avoid you having to collect the form that particular provider requires. So a lot of time was spent just chasing down forms and having to, fill them out and, the way that the provider requires. So a lot of that is no longer necessary. It also, you have one form where you could put all this information on, like for instance, I know Nick was talking about how difficult it is to get information post AOT, but you could actually put on this form where the form is good for a couple of years, and you indicate that you'll be tracking down information beyond the end of the program, and you get it in writing. So it's just really helpful. We're probably going to have another webinar just on the issue of confidentiality, and we can cover this in more detail at that point.
Leslie's asking if that form is available on our website. I think it is, right?
Yeah.
I believe so, but I'll add the link to the chat box, Leslie.
Elizabeth, what do you think about the potential for AOT programs to like maybe partner with a local university and develop something that could actually be published in a academic journal? Do you see that as something that's reasonably doable?
Oh yes, definitely. I think in terms of the big P program evaluation, looking at outcomes and is a local university would be an excellent partner. They have, most local state universities have invested interest in the community. And, there's usually, I guess, with COVID times, these may be different, but a lot of students looking for projects and especially research projects or PhD dissertations, whatever it may be, that there will tend to be great partners in things like this. So I highly recommend establishing relationships with a local university because they can, utilize their resources in some of the more analysis side of this. But data collection is, they'll need some, I think that infrastructure and building data collection into the workflow would be, a local university would need some of that in order to get started. So it's another reason to do
Right.
data collection as part of the program, operating the program.
Also, the there's not a lot written on AOT. We have the evaluations from the New York program, but aside from that and some data from North Carolina, there's really very little data out there. So a well-done evaluation has a high likelihood of publication, I would guess.
For sure. I mean, what we really need, I think, are comparative studies, right? I mean, we have a number of studies that have shown particular AOT programs to be effective, a couple that have shown particular AOT programs to be ineffective for reasons that I think are pretty easy to identify. But we really don't have anything that identifies the particular practices within AOT programs that seem to have an impact on how well they do. And there are so many variables, there's so many variations among programs. I think we all would really benefit from that. And I know that's something at TAC we're trying to bring into the world.
Yes, and that's why, you know, we've taken this spreadsheet that we worked on with Ohio and trying to take it nationally and urging programs throughout the country to be collecting, you know, specifically looking at the definitions of each of the variables. And, you know, we're more than happy to walk you through. I know it's really challenging to determine, you know, how to apply the definitions to a specific program and how it's operated, because every program is operated a little bit differently. But you know, by following sort of a similar paradigm, it will easily allow for comparison across programs.
Yeah.
Alexis Villegas has a question. Could you provide a few examples of types of analyses conducted with the data?
Yeah, so I think the most maybe straightforward one that is typical in when you're looking at AOT evaluations is understanding the reduction in psychiatric hospitalizations. As we all know, those tend to be the most costliest of services. So especially policymakers really pay attention to the fact of a program that may reduce the costs. And so an example of an analysis utilizing this data collection within that spreadsheet would be examining psychiatric hospitalization episodes, as well as the number of days in a hospital in the 12 months prior to AOT enrollment versus during and after. Another analysis that can be used is, I think, you know, similar to what Kelly was mentioning around the demographic data and trying to understand how differences in outputs, or so even number of status hearings or number of, you know, it could be that age may play a factor in the attendance to status hearings and how many status hearings or conferences an individual may need in order to succeed in an AOT program. And so there's a variety of different ways to analyze the data, looking purely at just the data that's collected during on that during AOT tab, not necessarily having to look at outcomes.
Alexis, do you want to follow up? I'll unmute you.
Yeah, that was pretty much my question. I was just kind of curious, like, were you like comparing means, doing like t-tests or looking at percentage changes with the clients? But yeah, thank you so much for your answer.
Well, thank you for your question. And, you know, I think maybe next we can do another webinar after everyone has started collecting some data to talk more about analysis, and we can go into some statistical comparisons and that sort of thing in a subsequent webinar if people are interested.
Amy, I think we had a question from Malcolm that says they have about 200 people on an AOT.
Oh, shoot.
And I can start that one. I would just say one person at a time. Just if you don't think you can do all 200 right away, a couple participants get into the flow of collecting some data.
Yeah, I could just give an example. Hamilton County here in Ohio has the same issue. And I think what they decided to do is they just broke out, I don't know if they randomly selected or, no, I think they identified those with various criteria. They took a subset of all their people that were in their program and started collecting just on the, I think, 25 people. So they just kind of bit off what they thought they could handle and started there. So you might want to think about like some kind of a pilot, you know, randomly select people and at least get you started.
Also, Mac, we're very happy to talk through that with you specifically at some point in the future if you're interested.
Yes, yeah, more than happy to talk about that and how to conduct a pilot data collection effort, or how to choose from the 200, that sort of thing.
You know, it's just, it's interesting because every county does a different AOT program, hospitals are different and all that. And I just, one of the, I don't know if quirk is the correct word, but you know, we often find, I find in my county that length of stay sometimes is determined more by insurance status rather than severity of illness. And sadly, we have folks with, I think, a pronounced level of symptoms who tend to have shorter stays if they're on Medicaid. And it seems that some of those folks, who I assume are either Medicare or private insurance, or for the relatively few private pay, have much lengthier stays that are independent, standalone acute or standalone psychiatric hospital. So it's interesting from a treatment standpoint, but it's also interesting then from a data collection standpoint, how payer source may have an impact on length of stay in hospital.
Mm-hmm. Yeah, and so that's, Nick, that's a great, so, you know, I would suggest to, in that situation, to collect the data on the payer source as well as maybe the hospital for each of the episodes. And, you know, the hospital source could be, depending on how many hospitals you have, we could make it a column within the spreadsheet or just do it as in the notes. And so by collecting the more detail into the hospitalization episodes, that will allow, you know, in any analysis to be able to understand, you know, what are the limitations of those and what other factors might be at play that are you know, either confounding or mediating that sort of variable around hospitalization pre and post. And I think that also speaks to, and this is something that definitely a local university could help with, if a program was interested in doing a larger scale evaluation. And it's definitely something we at the Treatment Advocacy Center can help with as well. But looking at, you know, in addition to this sort of programmatic data collection, doing some surveying. So, you know, you can do clinical indicators on symptoms, or you could do a quality of life survey. You could do a satisfaction survey at the end. So there's a variety of different, you know, measures that we could use to see if the program is having the desired effect beyond just sort of like the facts of how many days an individual is hospitalized.
Well, this whole session today has convinced me that I need to go find a doctoral level student to do this, because it is so difficult to try to implement this in the day-to-day workings of my job, and I'm sure that's the case for most of us. And so yes, I think utilizing a university and getting a grad student or undergrad would be a great way to to tackle this.
Agreed.
Well, I hope that that's not the end. I don't want to end on that, because that was the whole purpose of the webinar, was to urge people that that's not necessarily the case. You know,
Thanks a lot, Nick.
yeah, that you don't necessarily need the outside. I think, and that's why I think thinking about big P program evaluation, which you're trying to understand the overall the impacts of the program in a higher level, broader sense, versus process evaluation and programmatic improvements, and trying to understand your program outputs, and that level of detail, which can also be really informative and beneficial to any program operation. So starting small, and then tackling the big P program evaluation later.
I'll mute myself so I don't get in more trouble.
So Cassandra wanted to ask, has anyone been charged a fee for medical records?
Huh.
And if my experience in agencies is that they don't charge typically for hospitals, things like that, don't typically charge. However, we would charge if the records were requested by a subpoena for a court case. But other than that, we hadn't charged. But I'll leave that open for anybody else. Just raise your hand and I'll do my best to unmute you. And
well, I think that speaks to the importance of having the hospitals as part of your AOT team. In your quarterly meetings, they need to be engaged in this process, and they need to see the benefits of this data collection. Because certainly hospitals have, in my opinion, one of the greatest to gain from a quality AOT program. So it would behoove them to share that information to the extent possible.
I want to thank Elizabeth and Kelly for joining our network today and sharing this stuff. Is really great, super helpful.
Thank you for inviting us.
absolutely.